So if an ankle dislocation presents to you in the ER, it needs to be immediately managed considering all the complications including neurovascular, skin complication and compartment syndrome. Okay. It is usually associated with ankle fractures, bimel, trimel, tibial plafond or talus. Okay. So first you need to stabilize the patient, give adequate analgesia or sedation. So the reduction maneuver is very specific. First things first, you flex the knee to relax the gastroc. Okay. After which you hold the foot with one hand and the heel with another hand. Okay. And you give longitudinal traction with an assistant giving counter traction from the distal femur or leg. Okay. So you continue sustained longitudinal traction to disengage the talus from the tibial plafond. Okay. Now the next step is to reverse the deforming force. Okay, so in case of mediolateral dislocation, you have to reverse the deforming force or the mechanism of injury. So if there is varus angulation, you continue the sustained longitudinal traction and you gently apply the valgus force and look for clinical reduction. If there is valgus dislocation, you continue sustained longitudinal traction and you apply varus force. If there is posterior dislocation, you gently plantar flex the foot to disengage talus, following which you dorsiflex with a continued longitudinal traction. And if there is anterior dislocation, you translate the foot posteriorly along with pushing the tibia anteriorly. Okay, so the basic crux idea is to reverse the deforming forces. And immediately after reduction, the most important thing is you have to check the distal pulse. So post reduction, you immobilize in slab. Okay, you get a CT scan done and then plan the definitive fixation, which could be X-fix or definitive fixation directly.